Beautiful. Why don't we get started? It's so nice to see so many names that have joined the session. Welcome, everyone. And to save time, we're going to get started right now. So, welcome and thank you for joining us. This session is 2A Buprenorphine XR Alternative Induction Strategies for Challenging Cases in the Age of Fentanyl. My name is Katie Dunham, and I'm the moderator for this session. Before I introduce our speakers, we will just go over a couple of reminders again today. The session is being recorded. If you have a question during the session, you can use the Q&A chat box on the bottom. You are also welcome to put it in the chat and we will see it there. Also, if you're responding to any of the questions from the speakers, please use the chat box so that everyone can see how you're communicating. You can add comments, either way is fine by us. Once the presentation is over, you are welcome to raise your hand and we can unmute you and you can ask questions directly. Now I will introduce our speakers for the session. So Dr. Monique Moller is a staff physician at CAMH and assistant professor at the University of Toronto. She founded the Addiction Consult Service at CAMH in 2021 and is involved in emergency care, the COMPASS outpatient program, and the substance use intervention team at UHN. Tianna Costa is a clinical pharmacist at CAMH, specializing in concurrent disorders. She is currently the advanced practice clinical lead at the medical withdrawal unit and teaches at U of T. And Jessica Munro is an NP who has been working with the Interprofessional Pain and Addiction Recovery Clinic program at CAMH. Jessica is an ECHO Chronic Pain Hub member and U of T adjunct lecturer. Welcome, Monique, Tianna, and Jessica, and I will hand it over to you now.
Thanks, Katie. There we go. Hi, good morning, everyone, and thanks for joining us in this talk today. I have to say that since we were asked to do this talk, a lot has happened, so it feels like a really timely topic. And we're going to talk about some of those new things that have come out since. As you probably heard from the introductions, Monique, Tianna, and I all work together at CAMH in Toronto. And what links us is our work in COMPASS, which is a RAM clinic. So we have a RAM and fit-in service for concurrent and addiction services at CAMH. So we see lots of patients. We have a fit-in model, so patients can come once they've been seen the first time. They can come 9:30 to 3, Monday to Friday. We try to make it pretty low barrier, and we've increasingly been encountering lots of challenging cases and lots of high-dose fentanyl and other fentanyl-like substances in the community. And so it was something that we were seeing a lot here, and I suspect other people are seeing a lot. And there's been lots of chatter on Medify to support that. And so we're really excited to have this conversation with people, and we really do want it to be a conversation. Next slide. We have no conflicts of interest. We don't work for any of the pharma companies. And learning objectives for today are really to review the standard and off-label options for starting, which we would call Sublocade, buprenorphine extended release injection, the depot injection, and talk about some novel strategies to starting it, especially for clients that are a bit more challenging to treat and to get into care. So like I said, we want this to be interactive and a discussion, and we think it's really important to talk about it in our community. And so what we want to know is, what are you hearing about Sublocade in your community? Is it something that's being used? What are the good, the bad? What are the challenges? Are you prescribing it, administering it? Are you a patient who's on Sublocade? So a little bit about maybe you and your experience and maybe why you're interested in this conversation. As an ECHO Hub member, I love that people put their names and where they work, because it helps me feel like I know the audience and who's out there listening and participating. I don't know if I can see the chat. Oh, there we are. I see Diana from Correctional Services is here. Anyone else able to? St. Joe's. Oh, Miramichi. I went to UNB. I know New Brunswick. UHN, prescriber, Woodstock, prescriber, harm reduction, psychiatry, Sinai ED. I was at Sinai for 12 years. Hello, Sinai colleagues. NP in Toronto doing outreach in CHCs. Lovely. Psychiatrist Montreal. Bridgepoint St. Mike's. lots of need for Sublocade at Bridgepoint. True story, I gave the first Sublocade injection at Bridgepoint when I was working at Sinai in the TPS service on my bicycle during COVID in scrubs. RAM, Guelph, Stonehenge, hard program to get into. Oshawa and Aurora. Oh, I love it. I love it. Okay, so keep it coming. We can sort of scroll through and take a look, but it gives us a sense of the community that's here. And just to sort of frame this conversation, just a reminder that really the goals of treatment, like why are we talking about this? Why does Bup XR matter? Our number one goal is to keep patients alive. And it's really been a game changer in that regard. And so, we're always trying to initiate patients onto treatment to maintain their tolerance, to decrease overdose. We know that OAT reduces mortality. There's lots of evidence to support it. And like ultimately, once we're able to keep them alive, that sort of Maslow's hierarchy of needs, we want to stabilize patients so that they're well enough to then find housing, find employment, find meaning and purpose, and engage in relationships and social supports. And so it's sort of a stepping stone in that direction in a lot of ways. And we really want to meet people where they're at. We offer recovery-based programming, counseling, treatment of comorbid health conditions, but it's got to come from the clients and the patients that we serve, and we want to take care of them as best we can. Tianna, I'm going to turn it over to you.
Yes, thank you so much. So I'm going to talk a little bit about the pharmacology and the kind of basic principles of buprenorphine. And we know that buprenorphine has been around for a long period of time. Bup XR has also been around for quite a while now. And so I think a lot of us are familiar with that, but really just want to get us all on the same page as we start to look at perhaps why Bup XR might be easier, but also why we might need to find some alternative induction strategies for some of our clients. So we know that buprenorphine is a partial agonist, and this is what really gives it its superior safety profile. But along with this comes the fact that it can lead to precipitated withdrawal. And so precipitated withdrawal is really related to the initial dose of buprenorphine. And I'm sure many of you guys are familiar when we give higher doses to someone who's not in withdrawal, we see precipitated withdrawal versus if we're doing more of a microdosing protocol, we're giving smaller doses when someone's not in withdrawal, we're not seeing the precipitated withdrawal. Mu opioid receptor affinity. So this is relative to the opioid that a person is using. We know that buprenorphine has a very high affinity for the receptor. And so comparatively, how much will buprenorphine displace that other opioid? Lipophilicity, so how lipophilic a drug is, basically means that it will have a higher onset of action. It's going to be able to pass through that blood-brain barrier more quickly, but it also stays in the body for a longer period of times because it partitions into the tissues. And so this is highly relevant for fentanyl, which we would sometimes consider a short-acting opioid in that, people have to use multiple times a day. It doesn't last for a long period of time, but it does stay in the body for a long period of times. And this has implications when we're starting buprenorphine. The intrinsic efficacy, so how much an opioid will activate the receptor. And so we know that buprenorphine has a relatively lower intrinsic efficacy compared to something like fentanyl. And I alluded to the elimination pharmacokinetics, but how long is that opioid in the system really plays into the risk of precipitated withdrawal. And we also know that the induction outcome when someone is being started on buprenorphine can be related to their level of opioid dependence, their genetic makeup, comorbidities, as well as their prior buprenorphine experience. Having said that, we actually don't have a lot of evidence in this area. And so some of this can be quite challenging to navigate. Many of our patients are also using polysubstances or multiple different substances, and we know that polysubstance use and withdrawal can also alter the buprenorphine induction experience related to pharmacokinetic and pharmacodynamic interactions, which further makes this picture quite difficult. And then something else I wanted to mention is that continued use specifically of fentanyl or high potent opioids increases the likelihood of desensitization and internalization of the mu opioid receptors. And this actually increases the risk of precipitated withdrawal because buprenorphine needs a sensitized receptor. And kind of to put it very simply, it needs an available open receptor in order to bind. And buprenorphine, though, however, can resensitize these receptors. And we're kind of using this pharmacological basis when we're using things like microdosing or macrodosing approaches, because the more that we give buprenorphine, the more we're able to resensitize these receptors and people feel better, which is also one of the reasons why we treat precipitated withdrawal with more buprenorphine. And so I'm going to talk a little bit about this, just I guess using more of a pictorial or graph approach. And so we'll orient ourselves to this graph, and it could look a little bit confusing, but I think it makes sense while we go through it, or I hope it will. So the bottom x-axis indicates our pre-buprenorphine state. And so basically this is showing prior to buprenorphine, is a person in withdrawal, and this is indicated by our negative values, or is a person in a agonist state? So they have opioids in their system, they're feeling good. And then our y-axis over here is our post-buprenorphine state. So after we give buprenorphine, are they in withdrawal as depicted by these negative values, or are they feeling good? Are they in that agonist state, which are these positive values? And then on our right y-axis is the probability of precipitated withdrawal. And basically what we're seeing here is if prior to buprenorphine, they're in withdrawal, so kind of this top left quadrant, and we give buprenorphine, they're more likely to experience this agonist state, aka a successful induction and a low probability of withdrawal, versus if a person is in an agonist state prior to buprenorphine, they have an agonist in their system like fentanyl, and we give them buprenorphine, the more likely they are to experience precipitated withdrawal, as indicated by this high probability and these negative values. But what I also want to highlight here is that depending on the the opioid that they have in their system, their induction can look a little bit different. And so probably what you're seeing in practice is that inducting someone on buprenorphine when they're on fentanyl can be a little bit more challenging compared to something like heroin, which I feel like we don't see as often, methadone and morphine. And this is really related to the fact that fentanyl is highly lipophilic, it has a high intrinsic efficacy, and also a high affinity for the receptor. And then again, just kind of depicting this here. So this is our x-axis is showing the pre-induction opioid balance. So similarly, prior to buprenorphine, is someone in withdrawal or is someone having those agonist effects, they're feeling good, and this being the risk-benefit ratio. And so you see here, if someone is in withdrawal, we probably want to do a macrodosing protocol. This has a higher benefit to risk ratio. We need to give them higher doses of buprenorphine in order to manage that withdrawal. Versus if someone has that agonistic effect, they're using fentanyl, we're likely going to have to do a microdosing approach. And again, this is depicted by the height of the polygon indicating a higher benefit to risk ratio. And then quite literally here is our gray area. And I think the part that we struggle with most is when a person is not in withdrawal, but they're not necessarily experiencing those agonistic effects from fentanyl, how exactly are we going to start it? And yes, we can use a microdosing protocol, but this takes a long period of time, and often we lose people to treatment. And so we do have to be mindful of this risk to benefit ratio, and then be mindful of the client that we have in front of us and what's going to work for them. And so this is where buprenorphine XR really has become a game changer, but I think we're also struggling with how exactly should we start it. There's a lot of deviations from the product monograph. There's new product monograph updates. And so really, Jessica, Monique, and I are here today to talk about these alternative strategies to get people on buprenorphine XR, which I'll probably be calling Bup XR. And so this is just depicting some of the mean plasma levels, comparing transmucosal buprenorphine or sublingual buprenorphine versus the Bup XR. And so what you see here is With transmucosal buprenorphine, a person is going to take a dose usually every day, and we're going to see these rapid kind of like peaks and then troughs, and this relates to a person kind of taking it every day. Versus if a person gets the injection on day one, we see that there's a pretty rapid rise in the plasma concentration, a steady decline, but then it plateaus, and we don't really see these variations in plasma concentrations. Here are some clinical pearls, and this came from brain imaging studies, which basically showed that if a person has a plasma concentration of 1 nanogram per mil, this results in approximately 50% of the opioid receptors being occupied, and this likely will relieve opioid withdrawal symptoms. I should note that this is in volunteers who are using heroin, which again is quite different than fentanyl. They found that a plasma concentration of 2 nanogram per mils resulted in a 70% mu receptor occupancy, and this was felt to control withdrawal symptoms and cravings. And then finally, a 3 nanogram per mil resulted in 80% mu receptor occupancy, and this blocked the reinforcing and euphoric effects of commonly used opioids. Having said that, I don't necessarily know if we see all of this when people are using fentanyl, and so perhaps we do need higher plasma concentrations. And so the average plasma concentrations that we're getting with Bup-XR at steady state are approximately 3.21 nanogram per mil if someone is maintained on the 100 milligram dose, and 6.54 for the 300 milligram dose. And so again, this is a lot higher than that 3 nanogram per mil threshold that we think we need to relieve withdrawal symptoms, relieve cravings, and block those euphoric effects. And then to highlight here that we see that the steady state concentration of Bup-XR again has no daily variation, and the bioavailability is approximately 6 to 8 times higher than sublingual buprenorphine. We also know that higher buprenorphine levels may protect against fentanyl-induced respiratory depression, and so having these high levels of bup in the system is actually protective from an overdose perspective. A little bit about the dosing, and I'm sure many of us are aware of this. Bup sublingual is usually dosed daily. It can be dosed every 2 days. I've never seen that in practice, but given the longer half-life, theoretically it could be. We see a peak effect in about an hour and a half, and then the steady state concentration will happen about a week after regular dosing. With the Bup-XR, the product monograph will indicate monthly, and many of you guys are probably aware of the FDA product monograph updates that came out last month, which states that the second injection can actually be given up to a week after the first injection, and we'll talk a little bit more about that. And as Jessica alluded to before, Bup-XR is a very common thread on the Medify listserv, and so we are seeing that a lot of people are talking about it, giving it more frequently than monthly, and hopefully we'll be able to talk and generate some discussion around this as well. The half-life being 43 to 60 days, and the time to steady state is 4 to 6 months. And so I think this really speaks to the fact that why a loading dose might be helpful for these clients in order to get those steady states a little bit quicker. And so I'll pass it over to Monique.
Thanks so much, Tianna. Okay, so just some counseling points, some clinical discussion points to have with your patients before potentially initiating buprenorphine extended release. These are sort of lifted from some Medify materials, some of the 300 documents that Kate Hardy was referencing this morning. Such a wonderful resource and something I use every day in the emergency department to teach residents and fellows and medical students. So thank you so much, Medify, again, for creating that. So just reminding folks that if they do initiate this treatment, that they should not experience precipitated withdrawal once they are on and maintained on buprenorphine XR. They can still take fentanyl. It shouldn't make them sick. But they may get less high and in fact not feel the euphoric effects of fentanyl if they do initiate Buprenorphine. That's really important, and I think something maybe that we don't talk enough about with clients. You know, we really need to be meeting them where they're at, and if their goal is not to abstain, and if their goal is to continue feeling the euphoric effects, this may not be the best treatment for them. But you could tell them that this may actually be really helpful for them in their recovery journey, because it may make them less tempted to use opioids in an ongoing way. They'll have less reinforcing effects of the fentanyl or the opioid that they're using, and this could be really advantageous for them to get into some additional recovery programs. It will help control cravings and withdrawal symptoms if it is effective for them. So we can tell them they won't have to continue to use their opioid of choice to avoid being sick. It becomes more of a choice, so kind of reducing that compulsive drug-seeking behavior. And a really, really important one is we have really great evidence to support the fact that buprenorphine XR is protective against overdose. In fact, all OAT is. And then lastly, reminding them that they may not render the sort of optimal or full effects of this treatment immediately. So first of all, after the injection, the time to peak is 24 hours. In fact, it may take a few days for them to feel a bit better. And so they may notice the effect getting stronger over this period. It's important to monitor for sedation during that time as well. And it may take a few injections for them to feel better overall. So the steady state is usually achieved around 3 to 4 injections, and sometimes it takes that long for people to feel fully stable on Buprenorphine. Next slide. Some clinical considerations to also think about. So if you have patients who have a comorbidity of respiratory compromise or suppression or CNS suppression, it's important to remember that, as Tianna was speaking about earlier, the serum concentrations of XR versus SL are much greater. So we need to monitor for sedation, respiratory depression after the depot injection. And if you have somebody that you're worried about with this, it may be a good idea to admit them to hospital if you have that ability to do so, or having them check in at the clinic for a couple of days, making sure they have supports at home if that's a viable option. If they have a history of QT prolongation, you may want to consider doing an ECG before and after the depot. I'm not seeing this very much, honestly, but it's a possibility that you need to consider. And it does state in the product monograph that this could happen. So if you have patients who are maybe a bit sensitive to this, maybe they've had it with methadone, maybe they're on a number of QT prolonging meds, it's recommended that you do an ECG. There are case reports of severe liver disease and death with buprenorphine, not just the extended release, but buprenorphine in general. It's unclear whether there's a correlation here, but it is contraindicated. This treatment is contraindicated in patients with severe hepatic impairment. So if they have physical findings of cirrhosis, liver failure, encephalopathy, ascites, or jaundice, this may not be a good option for them. It's recommended to monitor liver function tests closely. It's recommended to use caution in people who have moderate hepatic impairment or cirrhosis or impaired liver function. If they just have transaminitis and there is no clinical evidence of dysfunction, this would not be a contraindication to monitor to initiate this treatment, but it is recommended that we would monitor closely. And then lastly, for people who are of childbearing age, who physiologically can bear children, important to screen for pregnancy and also counsel on contraception and doing a beta HCG, not just at the initiation of treatment, but also with repeat injections. And I think that's also something we kind of forget about, but it's something to remember and to counsel on each time. Okay, so these are the different induction strategies we're going to be talking about today. So most of you are familiar with the traditional induction method. We'll talk about the new FDA product monograph updates and where that kind of came from as well. And then macrodose followed by the extended release and then cold induction. So traditional induction, this is what was originally stipulated on the Buprenorphine product monograph, where patients would first have to undergo a stabilization phase using transmucosal buprenorphine containing products, also known as sublingual or Suboxone. And we would need to be delivering the equivalent of 8 to 24 milligrams of buprenorphine for a minimum of 7 days. Now, this is obviously very, very challenging for what we would probably consider a treatment refractory population in many cases, as this protocol is very time consuming. It requires patients to follow up daily for doses, to come to clinic often. We would find that we would need to be restarting folks many, many times over. And it may cause prolonged periods of withdrawal symptoms if they're actively using, or again, just like longer start times with micro inductions, again, often resulting in like repeat restarts. So overall, just like a delay in getting on treatment and significant reduction in treatment retention. That's been in our clinical experience. And so we need to start thinking about different strategies to get folks on this treatment much more quickly. I would say that I haven't seen a lot of this traditional induction method happening really in our clinic anymore. We are much more aggressive in the way that we get people onto this treatment. And so usually what we're seeing is like getting people on a higher dose of buprenorphine, you know, even on day 1 or 2, and then doing the depot injection the following day. But we'll talk about the macro induction protocol in a few slides. So this is the new rapid start as per the FDA product monograph update. So this came from a big trial that I was actually involved with at CAMH as one of the multi-sites that were involved in doing this study called Transform. The oral presentation at CSAM spoke about the evidence where it was a big randomized controlled trial where we evaluated treatment retention at injection 2, administered 1 week after injection using a standard induction protocol versus a rapid induction protocol onto Bup XR. So essentially what we did is for one group, we randomized to a rapid induction where we gave 4 milligrams of Bup sublingual, and then 1 hour later, we followed it with an extended release 300 milligram dose as a depot. And then 1 week after, this was followed by a second dose of 300 milligrams. And this was compared to a standard induction protocol where patients were initiated onto buprenorphine in the standard way, as we talked about in the previous slide. And this study showed with over 700 patients that the rapid induction treatment was superior to the standard induction treatment with respect to participant retention through to injection 2, and the retention rate difference was 11.82. So it's a pretty significant difference there. So we're really reassured by that. And for this reason, it seems like the FDA was able to update their product monograph. Health Canada hasn't followed suit yet. So that is also important to know that this is not necessarily an approved way to do this in Canada. And if you are doing this in your communities, that this would be considered still an off-label initiation protocol. So macrodosing, this is something I do a lot in the emergency department. My gosh, it's so satisfying when it works. And I really want to, again, thank Medify for the wonderful algorithm. And I just want to redirect everyone to their website to reference that algorithm that I, again, use on a daily basis to teach residents and fellows and our psychiatry colleagues. It's really great. So this is a way to initiate people onto a therapeutic dose of buprenorphine pretty much immediately when they're in withdrawal, after you've kind of ruled out different contraindications, and then transitioning them immediately to the buprenorphine extended release formulation. So what we do is we make sure that they're in sufficient degree of withdrawal, COWs of 13 or greater, they have no contraindications. We give them buprenorphine sublingual 16 milligrams. We reassess in an hour, and we either repeat that dose, either 8 to 16 milligrams sublingually until their withdrawal symptoms are resolved or sedation is kind of moved on, or sorry, that there's no sedation. And then we might consider doing the Bup XR, or we can just give Bup XR right after the 16 milligram dose. So we can do this in the same day, an hour after. And we've treated lots of folks this way, particularly those who are very transient, have a high risk of leaving AMA, have a high risk of overdose, and it works really, really well. And we haven't really seen many cases of precipitated withdrawal. So that's been really reassuring too. Next slide. And lastly is the cold induction. And this one's a little bit more in the gray area. And also, again, kind of speaking to the fact that we need to be a bit more inventive and a little bit more cowboy, I'll say, when the risks are so high if we don't initiate someone onto treatment right away. And so in this case, we would balance the benefit of giving this treatment in a very off-label procedure to outweigh the risks. And so this is when we give the extended release formulation without the sublingual right off the bat. And it's considered this rapid micro-induction. And it's kind of speaking again to the pharmacokinetics that Tianna reviewed so beautifully earlier. We know that extended release has a slower onset. It peaks at 24 hours. And so if you give the depot, what happens is it slowly displaces fentanyl and allows the receptors to resensitize and allows buprenorphine to kind of creep in and become the primary agonist. And we know that further doses should add this cumulative effect or agonistic effect and hopefully suppress withdrawal symptoms. It can be combined with sublingual if the patient will allow and if they're able to stay. So that can be a little strategy to use as well to help improve retention and also help them get onto a therapeutic dose more quickly. We know that on the Medify listserv, again, such a valuable resource, that providers are reporting doing this with minimal precipitated withdrawal. And we also know that this approach can be considered when managing missed doses. So for instance, if somebody has initiated Sublocade or buprenorphine XR many months ago, many moons ago, and they just haven't been able to follow up and they show up all of a sudden in your clinic and you're again worried that they're going to be at risk of leaving very quickly, they're very transient, that this could be a good option for them. You know, they've tolerated it in the past and done fairly well with it and they're still alive. So yeah, that could be a way too. Next slide. So mental checklists that I kind of go through and I talk a lot about in the Emerge when we're considering this, and we've also done this in our outpatient clinic. Have they tried buprenorphine before and tolerated moderate to high doses of the sublingual form? So if yes, that would make me feel more comfortable to pursue this approach. We're ruling out allergy here and we're also ensuring tolerance. If they're using fentanyl, we know that they have tolerance. So of course, we're sort of speaking to the fact that they're high risk here. Have they had recent overdoses? If yes, this would strongly make me consider this approach. And we know, again, we're kind of looking at that benefit versus risk ratio here, and the benefit of giving this treatment almost certainly outweighs the risk. Are they using alcohol? Or knowingly using illicit benzos or other sedating substances? If no, this would make me also feel more comfortable. If yes, we might be a little bit more cautious and want to initiate somebody onto sublingual first, just to see how they do. Do they have any known medical comorbidities, which we were talking about before? So making sure to rule those out. Making sure they don't have recent exposure to methadone. So you can counsel them on this if a urine drug screen is not available at the time, but preferably you would obtain a urine drug screen to rule out methadone exposure. Making sure that they're not pregnant. And then also this would be for a younger, sort of healthier population. Next slide. Okay, so I'll pass it over to Jessica, and yeah, thanks so much.
Thanks, Monique. So this is the case that sort of sparked this whole idea in my head, and I hadn't had experience at this point. I was covering Compass one day, and this young man came in who had been on Bup and had actually been on Sublocade previous, but had been incarcerated and had been homeless and was really struggling. And so it had been, I want to say 6 to 9 months when I saw him last summer, and he came in, and I mean, he came in, and by the time he was seen, it was it was a Friday afternoon. It was a pretty busy clinic, and he had to wait a couple hours. He'd gone out and used. He was on the nod, but really his ask was, I want to be back on Sublocade. This was the most stable time in my life. He'd had multiple overdoses requiring EMS and hospitalization, and really was struggling. And he wanted to get back on Sublocade. And so he had actually come to the clinic a few months prior, and he'd been started on sort of a traditional microinduction with doses at the pharmacy daily observed, working up to like an 8 milligram, at least for a few days, to come in and get the Sublocade. But he kept missing days at the pharmacy and having to restart the process. So he came in again, and it was tried a different way with a blister pack that he could take home so that he wouldn't have to go to the pharmacy, which was one of the barriers. But when he came in and saw me, he'd given a 2-week microinduction at home, but it had been 4 or 6 weeks since he'd been given it, and he couldn't account for the time difference. He said he'd taken it every day, but the math didn't add up. And so the third attempt, when I first saw him, was that I said, come back. I said, can you come back like Monday morning? Don't use when you first wake up. We'll pay for a taxi. Just come into clinic. We'll give you 1 dose of sublingual, and then we can give you the Sublocade that day. And so he was going to try to do that. And so we spent weeks sort of chasing him, trying to get him to come in, and he just couldn't do it. He wasn't able to not use as soon as he woke up in the morning. And so I started talking to my colleagues, and it turned out, there were people here that were doing this, and I started looking on Medify, and I thought, this is something we should really be doing for people like this, that really, this is their goal. He wants to be on Sublocade. Like, we can't get him on it. So we went over, he was competent to go over all the risks of precipitated withdrawal. We talked about, what are we going to do, if you do go into withdrawal? We don't want to do it on a Friday at 3 o'clock when we're not here for the weekend. And he was ready to handle it. He continued to use very high doses. So I did the cold induction. So we did the 300, and he continued to use high dose IV fentanyl. But since last summer, he's actually done a lot better. Every month he comes in a little bit closer to being on time to get it. I think the first month he was about 7 weeks when he came in, and then it was sort of 6 weeks, 5 weeks, and then he came in on his own without having to be tracked down by our community workers. And he's done a little bit better, and we've been able to have conversations about he wants to. He has a son that he doesn't have a relationship with, and he'd like to have a relationship with, and he's sort of been able to stabilize his housing a bit more, and so it's really been a great outcome for him. He's still using, but he's using a lot less. And last time he came in, he said he has a partner and she wants to get on Sublocade, and would I do a cold induction for her? So I feel like in a lot of ways it's a really good story. We'll see what happens, but that was the introduction for me to why we need to be thinking about this and doing it.
Thanks, Jess. So this is another case that I saw at UHN at Toronto Western Hospital. She was a young 24-year-old female admitted for cellulitis, and she had received Bupexar 2 doses, in fact, while she was incarcerated, more than 6 months prior to me seeing her in the hospital. And she was admitted, for this medical indication, but had told me, and sort of reviewing her substance use history, that she was using fentanyl and stimulants, that she had had multiple overdoses requiring Narcan, and she would frequently leave hospital against medical advice, as per my chart review on Connect Ontario. She told me that she wanted to restart the extended release buprenorphine, and I was meeting with her on a Monday morning, and of course she was admitted over the weekend. So several days into her being into withdrawal, her COWS was pretty prominent, 20, pretty significant withdrawal symptoms, and so looking at some screening blood work, her beta HCG was negative. She had a white count, but otherwise blood work was pretty unremarkable. This is like a fairly healthy young 20-year-old person. Her vitals were, a little bit elevated because she's in withdrawal and has a bit of an infection, but otherwise she's fairly stable, and she denied using methadone. And I got the call from internal medicine, hey, she's maybe going to be discharged later today or tomorrow morning. Do you guys have a plan for her? And, the question that I'm sort of grappling with is, do I macrodose? Do I provide extended release buprenorphine today or tomorrow? And so I guess, after sort of reviewing everything we talked about today, I was going to sort of put it in the chat, but I guess we'll probably leave time for questions at the end. The idea here is that we would really want to macrodose her right away. She's in significant withdrawal. We want to get her onto a therapeutic dose of buprenorphine. As she's interested in this, she's still with us in the hospital, and it will reduce her risk of leaving against medical advice. And then the fact that she's willing to start this treatment that she has tolerated before, I felt very comfortable giving her the injection the same day. Unfortunately, Bupexar is still not on the formulary at Toronto Western, so it requires us to, fill the script ourselves at Shoppers and walk it up to the unit ourselves and administer it. And she did really well with the injection, and she ended up leaving later that day. And we did not see her in the RAM clinic at Toronto Western, but my hope is that she followed up somewhere in the city. I am reassured that she got a treatment that will protect her against overdose. And that's also something to remember, is that patients are very high risk of having another overdose after they leave a healthcare setting or an incarcerated setting. And so giving them a treatment like this may significantly reduce their risk of overdose and dying after they leave our care. And this is just a reminder, Tianna sort of spoke about this earlier, that we can leverage the pharmacokinetics of the sublingual and the extended release formulations to be able to sort of cross titrate somebody onto this treatment in the same day. So even if you give a high dose of sublingual, that the time to peak for that would be about 3 hours. And then right away, if you give the extended release, that one is going to be a time to peak of 24 hours. So there's going to be this sort of cross titration effect where after 3 hours of sublingual formulation, the dose is going to kind of creep down, but you've given the XR, and that's going to sort of creep up over the course of the day. And so they'll be protected against withdrawal and cravings and overdose as well. And another reminder that if the patient is highly tolerant to fentanyl, that you will not suppress their respiration as long as they do not have another CNS or respiratory depressing comorbidity with buprenorphine. So this is a paper from 2006, which basically demonstrated that there is a plateau or ceiling effect in respiratory depression with buprenorphine versus more of a linear effect with fentanyl. And so they're tolerant to fentanyl, they don't have other sedating agents on board, they don't have these other comorbidities. It is safe to give high doses of buprenorphine, and they should experience this plateau effect. And if you are worried about them having any of those adverse effects, that you may maintain sort of monitoring them in hospital if at all possible, or increase contact in the following few days. I think, oh, this is my client too. Okay, so this is another client similar to Jessica's, where this was a patient involved or engaged with drug treatment court. So trouble with the law as a result of their substance use. 48-year-old guy, severe opioid and stimulant use disorder. He had also received Bup-XR during a brief admission post-overdose. That was many months ago as well. He couldn't tolerate being in our clinic for longer than an hour, and so we tried to give him Bup sublingual. He just couldn't do it. He just couldn't stick around. And he was also having multiple overdoses in the community, frequent run-ins with the law because of his uncontrolled substance use disorder. Otherwise healthy, you know, some hypertension, which is uncontrolled and not medicated. But he was not using methadone, not exposed to methadone. He had to do urine drug screens as a part of his drug treatment court participation. And we would consistently see fentanyl in his urine. He was also adamant that he did not want to go to pharmacy every day, sort of ruling out our ability to initiate him onto methadone or SROM. And he was willing to try the extended release, but again, he just couldn't stay in the clinic long enough to do the SL to XR. And so, you know, the question is like, for someone like this, would you consider doing a cold induction with this patient where we don't give the sublingual and we just go straight to the XR? And, you know, after reviewing the case with our amazing pharmacy team, such as Tianna, we felt comfortable to do that, and we initiated him onto extended release. So that is that case. Pass it on to Tianna.
Thank you so much, Jess and Monique, for going through those cases. So we'll talk a little bit now about some of the additional product monograph updates. So many of you might be aware that they have added more injection sites. So we are familiar with the abdomen as being our primary injection site, and they also added the thigh, buttocks, and back of the upper arm. And so they based this on a study that was published last year by Lafont et al., which included 88 participants. And these were people who were 18 to 65 years old. They had a, moderate BMI, so between 18 and 33. And they had a diagnosis of OUD and stabilized on 12 milligrams of sublingual buprenorphine for 7 to 14 days. So basically not the people we've been talking about in terms of if we did a macro dose or cold induction. And so these participants were administered 1 dose of Bup-XR, and then serial blood draws were done over the next 28 days. And so these are the 2 graphs from that study, and they're just basically showing 2 different time courses. So the first one being over the first 48 hours, and then this one being over the course of 28 days. And so what they found was that there was a higher peak of the buprenorphine concentration when the injection was given in the upper arm and thigh versus the abdomen and buttocks. And there was also a higher Tmax. So this concentration actually occurred at an earlier time point compared to the other regions. And they found that this difference is likely explained by the fact that there is a lower amount of adipose tissue in the upper arm and thigh versus the abdomen and buttocks, and this could impact the absorption rate of the initial dose of buprenorphine. Overall, though, they concluded that the plasma concentrations were comparable across all injection sites, and they determined that safety and tolerability was comparable across injection groups as well. I didn't include the graph here, but they do show on the graph that the pain scores for the abdomen were higher compared to the other ones. And this struck me as interesting. Although they did say that this was not statistically significant, I do wonder if it does have any clinical implications as well. And so we haven't done any alternate injection sites between, Monique, Jessica, and myself. So I don't really know how often these are being used or what patients are saying about it. And so we will be asking you guys, and I'm curious to see if any of you have experience doing this. And so hopefully we can get some feedback on that. And then the other product monograph update, and I alluded to this before, is that the second injection can be administered up or as early as 1 week after the initial injection based on patient need. And that was kind of the only sentence that's included in the product monograph. And there's really no other description of why you might use it. And so when we've been talking about who are these clients that we might want to do this kind of upfront loading dose in, we might want to consider it in clients who have failed previous Bup XR injections or initiations previously, if they are experiencing withdrawal symptoms or cravings within that first week. And so usually we are managing this by giving them sublingual buprenorphine as top-ups, but perhaps we might want to consider giving an earlier injection. And then if they have a high opioid tolerance as well. And so this is our next kind of polling questions. Just want to know what your experience has been with these FDA product monograph updates. Have you adopted them in your practice? Perhaps you've been doing this for a long time. And so we also want to know what your experience has been. So if you have been doing rapid inductions, so giving the injection an hour after a single dose of 4 milligrams Bup sublingual, if you're giving injections at different sites, and if you're giving your second injection a week after the first. And so if I can ask Monique or Jessica to navigate the chat, just because I can't see it with the screen sharing.
Someone said A and C, so rapid induction and second injection. Another person, Alex, saw 1 case of B and C. C, rapid injection, second week. Increasing frequency of second injection. Another C. So it sounds like that's the most common. An A.
Yeah. Thank you. I know Jessica and Monique and I were talking about, giving the injections at different sites. And we were thinking about like, how would it feel to have the injection in the buttocks with like, a lump forming and then having to sit down. And so I wonder about the feasibility about that one, but I like the idea of being able to offer people choice, especially when they have experienced a lot of pain in the abdomen. So thank you all for sharing your experiences, and hopefully we can chat a little bit more once we finish the presentation.
Seeing lots of questions in the chat and in the question and answer, and I recognize we're running out of time. So just around the precipitated withdrawal. So in my case, in case 1 with the 31-year-old male, he didn't come back to clinic for 7 or 8 weeks for his next dose. But I did ask him when I saw him, and he reported he hadn't had any precipitated withdrawal, but he had continued to use fentanyl, so he probably managed his symptoms himself. I do always offer a dose of 8 to 16 milligrams of Bup at the pharmacy as a daily dispensed, and they can miss doses for the first week. And then we also have really good access here, and so they can come back in Monday to Friday if they're struggling. I know that on Medify there were some studies with some precipitated withdrawal, but I have never actually seen precipitated withdrawal using the cold induction method, and I suspect it's because patients are actually self-medicating. I don't know if Tianna or Monique have anything else to add to that. Oh, and I just wanted to acknowledge, this is hot off the press. It actually came out just this week on Medify. This is a narrative review. It is sponsored by Indivior, but it highlights a lot of what we talked about today and just really the limited but also emerging evidence. And this table shows the published evidence for the various protocols that we talked about today. So it's a really good article if you're interested in this topic and you want to sort of pursue more, but it really is sort of a hot topic. So excited to be here today and have a little discussion. So let's get to the question and answer.
Thank you so much. Yeah, let's dive in because you have a heavy question and answer panel for sure. Thank you everyone for that submitted. I will just quickly flag if you could complete the survey for the chat today. If you liked it, which it was phenomenal, please do that before you leave the chat. Also, there are chat rooms in the general platform for the conference. So if your question is not answered today, please find the speakers, please find a chat room and continue to ask the questions there. We don't have to stop the conversation here. But to dive in, I've tried to divide your questions into different topics. There's a ton around the rapid initiation. So why don't we start with that one? For rapid initiation, could you tell us a little bit more about the study? What substances were being used for the clients that were in the study with the 4 milligram dose that then went on to have the injection, and how that was managed in terms of tolerance when you were going ahead and getting the injection? Why don't we start there?
So for this study, I can speak to that. There was a fentanyl negative subpopulation and a fentanyl positive subpopulation. So the data is divided accordingly, and I'm sure the publication will come out at some point in the next little while. But the subpopulation for fentanyl using or positive in the urine was 560 patients versus negative for 163 patients. So presuming that those patients who were negative were using other opioids. So hopefully that addresses that. So predominantly it was fentanyl using populations, harder to treat patients, higher tolerance for sure. Yeah.
Thank you. That's perfect. Okay, let's switch over to a ton of questions on the cold induction, of course. And I think the main ones that came up were in terms of how does this group feel in terms of allergies and tolerance? Is this just for fentanyl using clients? Could it be for any client? And then to add to the question list, a time from last use from which substance, including people have asked about methadone, of course, fentanyl as well.
Yeah, I can take a stab at that. The cold induction, we are limiting it to people who are using fentanyl, just because we do want to have an established tolerance. In terms of an allergy risk, I mean, the recommendation is that they've had buprenorphine, even sublingual, at some remote time in the past. So generally, we like to do that. The great thing about the cold induction is that time of last use doesn't matter. So even if a person used right before coming into clinic, we can still go ahead with the cold induction, because this whole idea is that the buprenorphine is going to slowly displace the fentanyl, kind of like what we're doing with a micro induction, just so much faster, and is going to peak at 24 hours when the fentanyl has really kind of left the system. And so then the other question though about using methadone with a cold induction, I have not, and I won't speak on behalf of Monique and Jessica, but my recommendation would be no. We know that methadone has a long half-life. It's going to still be in the system at 24 hours, and we're going to precipitate withdrawal, and that is going to be difficult to manage because by the time the methadone leaves, we're thinking about like 3 to 5 days before it leaves the system. And so I think it would be a tricky situation. So personally, I haven't done it, but would be curious if anyone else has.
Perfect, thank you. To tie on to the cold inductions after you've done the injection. So if someone has an injection, are you keeping them for a monitoring period at all? And when you send them home that day, I know you'd said a lot of people likely continue to go on to use. Are you giving them any medications, buprenorphine, sublingual, or other medications to support them? And for how long are you doing that?
So generally, these are patients who can't tolerate sticking around, so they usually leave clinic as soon as they get their injection. Again, these are patients who've usually been on Sublocade or at least on sublingual in the past, and so I'm not worried about an allergy or anything. And then I usually offer them daily dispensed doses of 8 milligrams of bup at their pharmacy, and they don't usually pick it up. I do that usually for a week, and then I mean, these are patients that we're having to chase and that aren't coming in. So it's, I try to find them when they're due for their next Sublocade, but I tell them they can come in, as early as the next week if they want support or help or another injection. I have used clonidine for patients that are in other situations, but not for this.
Okay, that's perfect. Thank you. Kind of a follow-up then with all of the different types of starting that you talked about. Someone had asked how you would approach someone that possibly has low to no tolerance if someone's just releasing from a facility of whatever kind. What would be your approach, especially if you're feeling that they are a high risk for returning to fentanyl use?
So I might defer this question to Tianna, but my personal approach would be to initiate them onto sublingual buprenorphine, like a low dose, and see what they tolerate, and then maybe gradually increasing the dose from there and monitoring them very, very closely, doing a lot of harm reduction counseling, getting them connected with care and services. And then if they are able to tolerate a dose, of 8 milligrams or more, then we might consider buprenorphine extended release if that's what they want. But again, just really counseling them on the risk, super high risk of the overdose following incarceration. But I would not do something like a cold induction or a macro induction or anything like that, just because they don't have the tolerance. And so we would just want to be a little bit more gentle and just have very close follow-up and a lot of counseling around that.
If the UDS confirms, because we all know that the substances make their way into the jails.
Yes, exactly. Yeah, good point. Thank you. Switching over to macro, I know there's been more talk about macro, the guidance that you pointed out, Monique, thank you. But there were a couple questions just about what your timing is for offering macro after last fentanyl use. And then from the first to follow-up dosing in a macro protocol, what are your cutoffs? How do you know if you give more dosing after the first 8 to 16 or whatever it is?
I go with the Medify guidance, which is 18 hours post fentanyl use. And so we try to give or take. Sometimes we don't know exactly, but we're trying to use that as a general time frame. Once we give the first initial dose of 18 or 8 to 16 milligrams, if we're not going to go ahead with the injection, like if they're still in withdrawal and you give the injection, like it's probably not going to help with the withdrawal. And so Monique can speak to this a little bit more, but we like to get the withdrawal under control with sublingual bupe before we go to the injection. And so usually we're waiting an hour between doses, sometimes 2 hours, because as I mentioned before, that peak effect is about an hour and a half after sublingual. So you can generally see how they're going to respond within that hour frame.
See Monique nodding, so I'll take that and we can move on.
I would just add that
yes.
With all the stuff that's out there these days, I have done cases where it was less than 18 hours, and if it was based on if their cows was really high, if they were scoring high, I would use that rather than the clock.
Thank you. Okay, there were quite a few questions also around pregnancy. So while this wasn't your specific topic for the presentation, if you want to dive into it, questions around how do you manage someone that becomes pregnant while they had been receiving Sublocade, or they want to start with the injection while they are pregnant?
I personally haven't managed anyone who is pregnant or wanting to become pregnant or I haven't had to navigate this question. I don't know if any of my team members have.
I've seen women in the pain and pregnancy program at Sinai, but it was like they were rotated to sublingual. That was the outcome.
Fair enough. I see a question that just popped up in the chat, and while it's still relevant, I'll actually jump to it. What do you do for patients whose withdrawal doesn't resolve while they're getting macro, now that we're talking about all these other types of starts?
Clonidine, gabapentin, depends on the setting, depends on the patient, but move to the adjuvants if you've maxed out your dose and still give the bupe, like give the XR.
I guess I'll add in then, does the injection sometimes follow or always follow your macro? And at what timeline does that happen? Especially since we're talking a little bit about the emergency department here, which is neat.
So in the patients that I've seen, if the patient is still wanting to go for the injection, we will still follow it, even if they're not fully responding to the macro induction, just reminding everybody that the serum concentration tends to be higher with the injection versus the sublingual form. And some people, for whatever reason, may not just be absorbing as much with the sublingual form as well. Like there's just like a high variability in the pharmacokinetic profiling of each individual. And so I would still recommend, if they do want to initiate this treatment, that we would go for the injection, and we would do so as soon as they're ready to. And then, as Jessica mentioned, using the adjuvant medication as needed. And then they can continue to receive top-up doses of buprenorphine SL if they need to after they've initiated the XR. So that sometimes can help resolve the withdrawal symptoms. And again, reminding that we can now give the extended release 1 week after. I mean, again, as per off-label product monograph from the FDA in the US, hopefully Health Canada following, but just documenting that that the patient is just not fully responding to the first injection, and that it would be reasonable and clinically indicated to provide an earlier injection, and hopefully that they would have a higher serum concentration after that.
And a good reminder from Catherine in Ontario about benzo withdrawal and our contaminated drug supply. So thinking about the other things in it.
Yes, thank you. And maybe last question, as we're very close to time here, and follow up to what you had just said, how are you finding, all of you finding access to the injection earlier than per monograph currently in Canada? So if someone's getting an injection a couple days after their first one, a week or 2 weeks after, any pushback that you've seen?
I have not encountered a problem. I write the prescription and the nurses pick it up at the pharmacy downstairs. It hasn't been an issue, which is interesting, actually.
I mean, I think it also speaks to the fact that we work in a very much like an academic setting, tertiary care setting, where our pharmacy team is very familiar with this. And sometimes it does require some support in communities for pharmacy team members to get on board with this. And it requires a phone call. And usually, you know, with a bit of education, things are resolved really quickly and there's access and it's fine. But it is a really important point to consider if you're in the community and maybe pharmacy team members aren't as familiar with what we're doing. Yeah.
Beautiful. Thank you all so much. We just rapid fired questions at you because there were so many. And I know we didn't even get to all of the questions. There were a lot of fantastic questions. So please do continue the conversation. Find our speakers in the lobby. There are many rooms that you can go to. There's a general room if you just want to have a chat and find a colleague. I did put the link again for the survey into the chat box. Please be sure to complete that before you leave. We are about to enter an hour-long break. You've made it. This is lunch, and sessions will restart at 1:30. So thank you so much to our speakers and to everyone that was here. It was fantastic attendance, and hopefully we'll see you all this afternoon. Have a good day. Thanks, guys.
Thanks, everyone.